Thank you. So here's, something that's a little bit more imaginary, and we want to make it a little bit more tangible for everybody. So functional GI disorders for your patients. I have no financial disclosures. So the objectives for this talk, we want to talk about some of the more common ones if we can and describe the workup to rule out some organic causes, as well as summarize some of the evidence-based treatment that we have for them. So if you find this schedule of abdominal pain, bloating, IBS, nausea relatable, please don't raise your hand, just blink twice. There are over 33 disorders of the gut-brain axis or gut-brain interaction, DGBI, which has largely replaced the terminology functional disorders. This is to help our patients feel like there's something behind their symptoms rather than being almost this imaginary type pain. So, DGBIs are thought to be more of a complex bidirectional communication network between the central nervous system, the integrating neural, endocrine, immune, and metabolic pathways. So as you can see, they affect all parts of the GI tract, but today we're going to focus on 3 of them: functional dyspepsia, irritable bowel syndrome, which has been talked about a little bit by my colleagues, and then functional abdominal pain and bloating. So we've seen since COVID hit that there's been an increase in the rate of DGBIs across our patients, just by more than 5%. And so you can see why we're seeing this maybe more in the office. So I have a couple of cases for us, so hopefully these are some relatable patients. We have a 66-year-old female with epigastric burning and mild nausea. There are no alarm symptoms, and you run, your normal labs and see that they're coming back unremarkable. So she's 66 years old. We decide to perform an upper endoscopy. So this is a normal upper endoscopy that you're seeing here. We perform the appropriate biopsies. H. pylori and celiac biopsies are negative. Why did we go towards a endoscopy? Because our American College of Gastroenterology says if you have symptoms of dyspepsia in somebody over the age of 60, you should consider an endoscopy to rule out any sort of malignancy. So eventually we diagnosed this patient with functional dyspepsia, which is defined by the Rome 4 criteria as the presence of one or more of these symptoms in the absence of structural disease we saw by the endoscopy, as well as imaging, if you've had that. So epigastric pain, early satiety, postprandial fullness, these can all relate to a diagnosis of functional dyspepsia. And there's so much data out there, some of it well supported, some of it not. So the truth is we don't really 100% understand the pathophysiology of this yet. So with that patient, the 66-year-old female, we've tried, to eradicate H. pylori if it was present, PPI trials, which a lot of patients are coming to us in the GI office having done that in the primary care setting. Notably, I wanted to say that there have been studies that a large one, it was about 20 years ago, but there was a 23% reduction in symptoms for patients over placebo using an H2 blocker. So don't forget about those. Neuromodulars like tricyclic antidepressants and buspirone can also be used. Prokinetics, I'm not a huge fan of these in the functional dyspeptic patients just because a lot of them aren't available. Domperidone, you can try to get it from Canada, and cisapride is not really available either. So we'll go into complementary and alternative medicine in some of the later cases, but remember dietary and lifestyle modifications. Shout out to our dietitians that are here today. So I think everybody's probably seen this patient, whether it's been in the endoscopy suite in the GI clinic or the primary care setting. A 32-year-old female with abdominal distension for about 2 years. It worsens throughout the day. She wakes up, feels okay, just can't get any relief by the end of the day. And she's tried everything that she's got ads for on TikTok, on Instagram, tried pre and probiotics, low FODMAP diets, and she looks pregnant, so please help her. First, I want to, try and decipher for those patients, is this upper GI bloating? Is this more lower GI bloating? If it's upper GI bloating, I'm going to consider more of the H. pylori. Also, of course, celiac disease. She is of childbearing age, so don't forget pregnancy. And then kind of discuss different procedures based on risk factors and alarm symptoms. There is SIBO testing. I know we don't have it within our VHC lab, but we do offer it through the clinic. So small intestinal bacterial overgrowth that can cause bloating and distension. Sucroisomalt deficiency testing. If they've had more of this bloating since childhood or teenage ages, that's more of the patient that I would tailor that to. As far as imaging, you can always use x-rays like we do to assess for stool burden. Also CT scans if we're looking at other organs such as the pancreas. Diet changes, gluten-free, lactose-free, low FODMAP, a gastroparetic diet, small frequent meals, all things that we can use to try and help these patients. Of course, CAM, we'll talk about soon too. And then gynecological evaluation. This is really important for our female patients. I will say, that not all abdominal bloating is GI, and I've actually had 2 patients since I've been here where we went through a GI workup and then, sent them to the gynecologist, and it was ovarian cancer. So please don't forget about that. Why is functional bloating important? Dr. Che, who's one of the giants in our GI world, he conducted this study, about 90,000 patients, and had 1 in 7 say that they experienced bloating. Of course, and these are Americans, they're not always coming into the office. Only about 29% said that they actually sought some care for their symptoms. Functional bloating is defined by the Rome 4 criteria by recurrent symptoms of abdominal fullness or pressure with visible increase in abdominal girth, with symptoms at least 1 day a week and active for at least 3 months. This can be associated with IBS, constipation, functional dyspepsia, so it's really hard to truly define, to be honest. So here are some of our initial complementary and alternative medications that I see a lot of our primary care starting to use. So here's a little bit more information. We use them in the GI office. So peppermint oil, as well as STW5, okay? Peppermint oil is over the counter, as is the other medication. For peppermint oil, again, upper GI bloating versus lower GI bloating. FD Guard, the trade name I use for upper GI bloating, but it can increase acid reflux, okay, because it has that peppermint in there. IB Guard, it's in a capsule, so it's able to reach the colon better and then release there. So patients, it's going to give a little bit more of an antispasmodic effect or help with that bloating. Make sure if your patients have atrial fibrillation, you're kind of careful with this, as well as I had a patient with a peppermint allergy this past week, so always check their allergies. For the STW5, it can help functional bloating. So I don't think it hurts to educate them about this and see if it could help them. Now, other therapies include central neuromodulators and other medications. So pregabalin has shown improvement in bloating through numerous studies. Also, biofeedback using EMG recordings of muscle activity. Tricyclics and SNRIs, again, we'll talk about in just a second. And then CBT and hypnotherapy as well. Digestive enzymes, controversial topic for my patients who don't have known pancreatic disease. I personally don't use them as they've not been recommended in any of our society guidelines, although patients do feel like sometimes they get a benefit from it. So here's our third case, last case. So a 46-year-old female who's been having diarrhea for a year. She wakes up in the morning with that urgency, has to run back and forth to the bathroom 2-3 times in the morning in a 2-hour span. Her lower abdominal pain that she gets, that pang, it improves with defecation, and she doesn't have any alarm signs. So hopefully you should have sent this patient already for a DCA, a direct colonoscopy, direct access colonoscopy, which is very easy to do. And so if that has not been done already, probably want to do a colonoscopy in a patient who is of screening age, as well as testing for different things that we've already done. The American College of Gastroenterology does say for IBS, you do want to try and rule out that there is celiac disease. Using a fecal calprotectin, a non-invasive measure to measure inflammation within the colon, doesn't matter what it's due to, but that's a very helpful non-invasive tool that we have now, as well as check their thyroid. If there are any alarm symptoms, of course, think about procedures. Now, again, irritable bowel syndrome could be like 5 talks on itself. So most of you I know in the room are familiar with it, and that it's not just one thing that drives it. It's very multifactorial, from the gut flora to the diet to the gut-brain axis, stress. And so what are some of these treatments that have been evidence-based that we can use for our IBS patients, whether they are constipation predominant, diarrhea predominant, and they've tried those conventional therapies that are available. So neuromodulators have been shown to help DGBIs, so don't be afraid to try and prescribe them. The Atlantis trial had over 450 patients, and it showed that low-dose amitriptyline was superior to placebo as a second-line treatment for irritable bowel syndrome. And so how do you use these medications, okay? There are tertiary amines, there are secondary amines. Tertiary are like amitriptyline and imipramine, and then secondary amines are nortriptyline and desipramine. So the tertiaries are going to be used in a lot of these studies, but they have more side effects. The secondary amines have a lower anticholinergic burden and generally better tolerated. So for a patient with irritable bowel syndrome with constipation predominant, secondary amines sometimes are the preferred method that I like to go for, because they help that patient who may have an exacerbation of their constipation. And so I typically start my patient at 10 milligrams, whether it be amitriptyline, nortriptyline, and dose it at bedtime, because it can be very drowsy, especially for your elderly patients. So you see for a week or so, are they tolerating the medication? I don't expect them to be having any benefit for their IBS at that point. So I generally tell them, even if they're having some side effects, try and stick it out for a week or two, and then we go up on the dose. Usually take 2 tablets, because that's easier than getting a new prescription, so 20 milligrams. And then gradually can even go up to about 50 milligrams. When you go higher than 50 to 75, it becomes difficult because you've maximized what you're going to get from the IBS perspective. You're not going to treat their anxiety and depression at that level, but they're going to get a lot more side effects. So this is something to just kind of consider. Another nice chart, if my patient has IBS, constipation predominance, and I don't feel comfortable going with that tricyclic antidepressant, there are SNRIs that are available to help those patients. And think about their comorbidities, such as fibromyalgia. It happens that patients come into the office and they're already on SSRIs, which may not improve their IBS specifically, and I just talk with their primary care provider to see, is there room that we could transition to a different medication? Now, there's other therapies available in this digital age. You can pull out your phone, get a lot of different apps. So Nerva and Regulora are really helpful, especially in an economy where some patients are losing their insurance and then regaining it, so they can have something on their phone available to them. GI Psychology is based out of Northern Virginia with psychologists, and they do telehealth appointments and really help take the burden off of us, co-managing a lot of these patients. My IBD patients, I manage some of their IBS with them as well. Now, there's the Monash app for low FODMAP. If you've not been familiar with this, it's really nice because it is able to show you green, it's a good food, low FODMAP. Red, it's not. Even figure out some recipes that you could use. Xifaxan, it's much better covered by a lot of commercial insurances if you use it under the diagnosis IBS-D, so that can be helpful, and it's just a 2-week medication for your patient. Virtual reality has been shown to help with pain processing, so maybe a way of the future. And don't forget about acupuncture. And then kind of lastly, so complementary and alternative medicine, it's a very broad group, and it's not widely taught in any medical school, advanced practitioner schools. And so there's 2 kind of subgroups to this, natural products as well as mind-body medicine. And so natural products, these are dietary supplements. The mind-body medicine includes procedures and techniques that can be done by a practitioner or by somebody, at home. Yoga, hypnosis, meditation, biofeedback. What are more natural products that you might see or use in your clinic? So for as far as herbs, and there's turmeric in functional dyspepsia, ginger in functional nausea, magnesium mineral, so for constipation, and then slippery elm in functional heartburn. The American College of Gastroenterology and American Gastroenterology Association do not recommend pre and probiotics. Of course, my patients are going to come in and ask me which one to take. So if I take one that has the most evidence behind it, and that would be Align, Culturelle, having that Bifidobacterium or Lactobacillus strains, as well as Visbiome or VSL number 3. If it doesn't really help, I tell them to save their money. Many studies have been done with kefir as a fermented food, so that could potentially be helpful in coming with IBS. As far as mind-body medicine, please take advantage of these digital apps and telehealth resources and alternative practices, really to help your patient and to help you as a provider. So the takeaways, if there are alarm symptoms, do act. Take advantage of these other therapies that are available because sometimes you only have 15 minutes in the clinic or 30 minutes and you can't get it all done there. Not all abdominal pain is or bloating is GI, so think about other relevant structures being the GYN or pancreas, et cetera, when you're thinking about these things. And just be patient with your patients. It's going to take it doesn't all happen in one visit. Okay.